Andrea and Kate, can you ladies hear me?
Yes, I can hear you.
How you doing?
This is Kay.
Hi, Kate.
Great. How are you?
Good. I see Richard just logged in. Just give him a couple seconds. Some people are still coming in, so I'll give it a few more minutes until we get started. I'll just give one more minute for everybody to finish logging in. There's still some people coming in, so I'll just wait one more minute. Okay, so I'll get started. If anybody has trouble hearing me or seeing the presentation, just kind of raise your hand or send me a quick email or shoot me a text, or everybody's all got the ability to unmute themselves, so you can just unmute yourself and log in, and feel free to ask any questions. This is a little shorter webinar than most of them ones I usually present, and it's on a topic that a lot of us often neglect. A lot of us are concerned with when we're doing the electrodiagnostic study, that we are looking at musculoskeletal stuff and we're focused in on nerve and neuromuscular things, but we have to consider that the nerves are just part of the body that can be just as easily affected by other conditions, and we have to look at the whole picture as a whole patient. So there's a lot of factors that we need to consider that can greatly influence our results of our tests. We often think that patients with medical problems, like we think of people with diabetes. Well, diabetes is very common, but there's many other things that we don't often think of that could have effects on the neuromuscular system. So I wanted to talk some stuff about that. Oops, hold on. Okay. So, as I mentioned, a lot of us work in, orthopedics and sports practices, and, we're focused on, radiculopathies and neck injuries and back injuries and work-related injuries and things like that. But one of the things that we focus on is the medications and the medical history when we're doing your reviewing of your reports. And the reason for that is not because we said so, but because it's going to greatly influence, what the person can present with. A lot of people, as I mentioned, they may have a radiculopathy, but they can also have long-standing medical problems that will affect their overall other systems, but overall their general health as well. So we need to take into account medications, because that will tell us what's going on. So it's important that we not just say, okay, it's on the intake sheet and just disregard it. We need to kind of understand and be more familiar with some of the more common medications, and I'll go over some of the more important ones that our patients may be taking that not only will affect their entire system, but the actual results of the nerve conduction study. For example, if somebody has COPD, we think of COPD as, a pulmonary condition, but the nerves need oxygen too. So if the person has COPD or peripheral vascular disease or some other kind of medical condition, that can often affect all the nerves. So even though they may not have diabetes, their nerve function may be severely impaired because the nerves are not getting the oxygen or nutrients or blood that they need to survive, which could cause, symptoms like a neuropathy, or like diabetes or things like that. So first we'll go over some medications, and I did quite a bit of research in different articles and different protocols that some physicians recommend that they sometimes ask the patient to stop taking these medications. Now, obviously, as therapy, you can't do that, but we want to at least be aware that the patient may be taking these medications because they can alter the results of the test. So the first class of drugs are anticholinergic drugs. These are commonly used for ulcers, intestinal system, irritable bowel syndrome, overactive bladder, but more commonly in the patients that I see when I work in a family doctor's office or get referrals from a family physician, is they're used to treat COPD and asthma. Some of the two more common ones are Atrovent and Spiriva. So to stay out of pharmacology class too much, the mechanism of action is that these drugs will block the effects of acetylcholine, which is good to treat asthma or to treat the overactive bladder, but it's bad because if it blocks acetylcholine, which is the primary neurotransmitter across the neuromuscular junction, then the muscles will not depolarize. If the muscles don't depolarize, then the person's strength will be altered. People taking these medications for long periods of time often present with clinically decrease in strength, but that can also affect the nerve conduction results. They can cause low amplitude responses of the motor nerve conduction studies. And with EMG, they'll see significant changes with decreased amplitude of the motor units and decreased recruitment, and I spelled it wrong, but decreased interference, because they just can't, they might present similarly like as a person with severe, well, not severe, but somebody with possibly myasthenia gravis, which is a neuromuscular junction disorder where acetylcholine can't bind to the receptors. So they have easily fatigued, difficulty with overexertion. So, and some of the findings in those patients in the EMG exam are the same findings that we'll see in patients that are taking anticholinergic drugs. So this is one of the important drugs that you need to document if the patient is taking. And as I said, most often they're used for treating COPD and asthma. Other drugs that are more commonly encountered in a more musculoskeletal population are going to be muscle relaxants. So obviously muscle relaxants are used to decrease pain and decrease spasms, because oftentimes the muscle spasm itself is causing the person's pain. And obviously their mechanism of action is that they're going to decrease the excitability of the of the muscle. Some of the more common muscle relaxants that people may be taking, and this is just a small list, but there's definitely more of them, but these are some of the more popular ones. Flexeril, Valium, which is also a sedative, Soma, and also gabapentin. Now, gabapentin or Neurontin is the brand name. Not only treats muscle spasm, but also is used for chronic pain relief, especially in patients if they're trying to avoid opioids. Gabapentin can help reduce spasms and decrease pain. So that's one of the more common ones you may see that has a kind of dual purpose, as decreasing pain and decreasing muscle spasm. And obviously, again, because they're acting on inhibiting the muscle, these medications, you'll see a reduced amplitude of motor responses because the muscle just can't contract when you even though you're providing a stimulus, the muscle can't contract or can't be activated. And again, decreased EMG recruitment. The motor units themselves may be normal because the muscle fiber potential is still okay, but they just can't recruit all the muscle fibers that they need because they're being relaxed. So you'll see a decreased recruitment pattern on the needle EMG exam. Other types of drugs can often cause neuropathy. So these are not as common, but these drugs can often be used, often cause a neuropathy. So even though we don't, during an electrodiagnostic test, we don't, label the cause of the condition, but these, we need to be aware if the person's taking some of these medications a long time, that when we send them back to the doctor and say they have a polyneuropathy, you have a dialogue with the physician. This is how you can increase your marketability and increase your presence with the relations with the physician, with the referring provider. That you can say, they mentioned that they're taking medication XYZ. That possibly that may cause, that's been known to cause neuropathy. So one of the more common class of drugs that cause drug-induced neuropathy are medications used to treat HIV and AIDS, but also chemotherapy. HIV and AIDS is not as common, but chemotherapy is because there's many types of cancer that are survivable. So we can see these drugs after a person sustains chemotherapy for various forms of cancer, that the drug, even though it saved their life by curing the cancer, it may have caused neuropathy. So again, you don't need to get a list of, you don't need to memorize all the specific drugs and what they do, but if the patient tells you in their history that they have a history of HIV or history of AIDS or a history of chemotherapy or cancer treatment, then maybe ask them be more diligent in the medications that and find out what they're taking. These drug-induced neuropathies, the good news is that they can be reversible if the dose change or if they're discontinued. So perhaps the doctor may know of a different medication to serve the same purpose. However, because it's affecting the axons of the nerve, they can take a long time to recover. Anything that's going to affect the axons will take several months to recover. Besides the HIV and AIDS and chemotherapy, what's interestingly is that more common, they can also be used to treat abnormal heart rhythms, rheumatoid arthritis, high cholesterol, and hypertension. Now, these are conditions that almost, I saw like 11 patients today. I would say more than half of them had, hypertension, high cholesterol. One clinic that I work in with a rheumatologist, and obviously all of our patients have rheumatoid arthritis, and a lot of them are having neuropathy symptoms possibly because of the medication that they're taking. So the doctor wants to know, is the medication causing this? So it's important to know some of the medications that can cause neuropathy. And if you click on the link there, this webinar is being recorded, but if you want me to send you the link, just shoot me an email. I can send you the link. These are all the medications that are known to cause peripheral neuropathies. So it's good to keep these as a reference, somewhere. You don't need to buy a drug, physician desk reference, but just keep these medications on hand, because these may be causing harm, and if you're going to be treating this patient, can be adverse to your efforts that you're trying to treat them for. The other class of drugs that can cause harm are drug-induced myopathies. Drug-induced myopathies, these are commonly encountered with patients taking long-term corticosteroids. So as before, we talked about patients with COPD taking long-term steroid use. to improve their breathing function, will affect the muscles, not the nerves, because it causes direct atrophy of type 2 muscle fibers, which are the predominant type of muscle fibers that we test during needle EMG. So with these patients, and if you, I'm not sure, about some of you I see are mixed in levels of the HODS and residency training. We haven't covered myopathies yet, but drug-induced myopathies are quite common, not only in the hospital setting, but also, as I mentioned, in patients with pulmonary conditions and long-term pain symptoms, because sometimes steroids can be used to treat pain. Anabolic steroids is another thing. I've seen a couple of people that take anabolic steroids for muscle growth, and they ended up with short-term muscle gains, but long-term, years later, they have classic myopathy signs where they're seeing very small amplitude motor units. They're seeing very small amplitude motor units, and they're seeing very rapid recruitment. Statins, besides corticosteroids, so medications for blood pressure and cholesterol, can long-term use can cause myopathies. Long-term exposure to antiviral agents. That's why, usually for viruses, they don't usually like to treat them with medication. They just kind of let the virus run its course. And also, not really a drug, but more of a condition, systemic lupus erythematosus. I can always mess up this, but SLE can also be associated with myopathies as well. So these are just some other conditions you need to be aware of that could cause myopathies instead of neuropathies. So the nerve conductor studies, for the most part, will be normal, but the needle EMG exam will be wildly abnormal. And then finally, I'd be remiss to say if I didn't talk about a little bit about medications that are not contraindicated for electrodiagnostic testing, but just to be aware of, is obviously the anticoagulant medications. There can be very many types, from Coumadin to heparin, Xarelto, Plavix, even baby aspirin or regular strength aspirin, and the regular over-the-counter NSAIDs like ibuprofen, Motrin, naproxen, Aleve. All of those medications, even if the person's taking them as not prescribed, but as indicated, they will thin the blood and will have adverse effects, and make them more susceptible for bleeding or bruising. So just ask the person everything that they're taking, not just prescription medications, because the patients will often forget to mention that, because people ask them, "What are you taking?" They only kind of seem to often reveal this prescription medications, but when you ask them what else are you taking, tell me anything you're taking, and then they'll say, "Oh yeah, I'm taking baby aspirin, or I'm taking this or that." So, or I just take Aleve, a couple times a day, whatever it is. So make sure that you're thorough, because these medications, while not contraindicated, can cause an increased risk for bleeding or bruising. In fact, I read an article that was published a couple of years ago that said patients with taking blood thinning medications, you may need to be special care around the paraspinal muscles, because patients that are taking blood thinning medication, the paraspinal muscles, especially the cervical paraspinal muscles, can sometimes lead to increased risk of hematoma, which are large kind of knots or big bulging bruises. So just be more mindful of patients taking any type of blood thinning medications when checking this paraspinals. It's not contraindicated, but it's just something to be aware of. So make sure you apply quick pressure right after you take the needle out, to kind of minimize any risk of excessive bleeding or bruising. So that kind of wraps up the medication part of it. Does anybody have any general questions or general concerns about certain types of medications or certain types of things to be aware of or to be concerned about, and why it's important that we know all the medications that a patient's taking, not just say, okay, see the intake list. So does anybody have any questions about medications specifically? Okay, so no, everything seems to be good. Okay, so I'll go on. And the other factor that I wanted to talk about is we're often concerned about medications and drugs and things like that, but it's also important to, again, look at the whole person and look about their nutritional status. Because patients who have altered nutrition, as I mentioned, and with patients with COPD, the nerves need oxygen too. So do the nerves need nutrition. So there are most of the vitamins. There are quite a few nutritional aspects that can alter the function of the peripheral nerves, and most of them are the vitamin B class. B as in boy. So the first one is vitamin B1 deficiency, also known as beriberi. And according to an article from 2013, patients with vitamin B1 deficiency will often present similar like patients with diabetes. Well, they'll have axonal compromise in the motor and sensory nerves that is worse in the lower extremities. So as you're doing the test and you're coming across these findings, you don't understand why, and the person is not, the person's not diabetic, you may, you can't order a blood test, but you may be aware that the person may not be getting all their vitamin B1 because they're getting axonal changes of the motor and sensory nerves that is worse in lower extremities. Also, things to note that vitamin B1, which is thiamine, patients that are athletes and pregnant women, even though we're probably not going to be testing many pregnant women, but athletes especially, again, thinking we're sports medicine and we don't see these people, but athletes actually require more thiamine than age-matched individuals. So you have your big strong athlete, and you're doing a test on them, and you notice that they're getting low amplitude responses of the motor and sensory nerves. They may not be getting enough thiamine. So that's something to be concerned about as far as getting an intake of what the patient's taking. There are some states that physical therapists are allowed to make nutritional recommendations as far as vitamin supplements. So maybe perhaps check your state practice act and see if this is allowable in your state. But regardless of the state, most states do allow you to at least take a comprehensive list of the patient's medications, and you can investigate and open up discussion with the doctor, primary care doctor, or further to one who may be able to do some further investigation. Another common vitamin B deficiency is vitamin B12 deficiency. Vitamin B12 is also cobalamin. The clinical indications is it has subacute combined degeneration, and it's very common in the older adult population. And especially the older population, it could be caused by a high vegetable diet. So, if your patient's going healthy and going green or going vegan and wants to be, friendly to the animals, unfortunately, we do need animal products. We need those animal fats, those animal products, and for the vitamin B12 component of it. Also, speaking about drugs that cause other problems, metformin, which is commonly used for patients with diabetes, can alter the uptake of vitamin B12. So, kind of patients that are taking metformin are often recommended to increase their intake of vitamin B12, either through shot or through tablets or capsules. Interesting to note, for patients with vitamin B12 deficiency, they will present with proximal demyelination in the lower extremities. So proximal demyelination in the lower extremities can often be confused with or similar to the patients with Guillain-Barré syndrome. Whereas in Guillain-Barré syndrome, we will see long segment or proximal demyelination, but just be aware, and Guillain-Barré syndrome could be life-threatening when it's encountered, but you need to find out if the person's what their vitamin B12 status is, because that can cause similar electrodiagnostic findings for patients with vitamin B12 deficiency. Another vitamin B, vitamin B6 or peroxidine. Again, of note for peroxidine, either a deficiency or an excess. So too much is no good and too little is no good. Can cause a peripheral neuropathy. So again, this is not a drug, but a nutrient where too much of it or too little of it can cause peripheral neuropathy. This can be seen commonly in patients receiving chronic hemodialysis. So kidney function on its own can affect the peripheral nerves, but then compounded upon that is vitamin B6 deficiency. So they can be seen in patients receiving hemodialysis. So they got double whammy as far as two things that can alter their peripheral nerve function. A suggested supplementation about 10 to 50 milligrams is recommended for all patients receiving chronic hemodialysis. And also, as I mentioned, too much of it in excess could be harmful as well. I couldn't find the exact number of how much is too much, but there can be too much of a good thing in the case of vitamin B6. As far as the electrodiagnostic findings in patients with vitamin B6 deficiency, we'll see primarily sensory changes. So you'll see reduced amplitudes of your sensory nerves in both the upper and lower extremity, which again often present similarly with patients with diabetes. Patients with diabetes will present with sensory damage to the axon damage to the sensory nerve fibers, but you're sure the patient doesn't have diabetes, or at least the patient knows they're sure, but you can encounter these findings in patients with vitamin B6 deficiency. Vitamin E is not as common, but it is possible. In vitamin E deficiency, vitamin E is present in, again, animal fats, nuts, and vegetable oils. It can be caused by either a malabsorption in the gastrointestinal system or a transport deficiency, so carried in the bloodstream could be difficult. Clinically, patients with vitamin E deficiency will present with lots of balance problems. They'll present with lots of balance problems and lots of weakness. So they'll present with loss of deep tendon reflexes, loss of balance, and generalized muscle weakness. For the electrodiagnostic findings, even though they're having balance issues and weakness, the most hallmark finding, which doesn't make sense, but this is a research that I found, is that patients with vitamin E deficiency will have axonal changes of the sensory nerves. So we'll see axonal involvement of the sensory nerves. As well, another article mentioned that these patients will, because it's affecting the balance system, doing a somatosensory evoked potential. So doing a somatosensory evoked potential study, because they're having balance issues, you can detect patients with vitamin E deficiency can be evident upon somatosensory evoked potential studies, because you'll see slowing or low amplitude, not slowing, you'll see low amplitudes or absent responses of some of the somatosensory evoked potentials. Finally, patients with bariatric surgery. So patients with bariatric surgery, one of the biggest risk factors for patients with after bariatric surgery is because now they have a smaller stomach and a smaller intestines, is that they don't absorb their nutrients as well. So patients after bariatric surgery have difficulty in the first few months being healthy because they're not getting the intake of the proper nutrients that they need. Electrodiagnostically, these patients will present with length-dependent axonal sensory neuropathy, again, which is very similar to a patient with diabetes. So again, we want to ask the person, if we ask them what type of surgeries they've had, a lot of times, I just tell you, I had orthopedic surgery, or I had surgery to a nerve, or I had carpal tunnel release, or I had, a laminectomy or a fusion or something like that. But they'll often neglect, surgeries that they don't think are cosmetic, or, unrelated to their nerve problem or to their joint problem. But bariatric surgery can cause neuropathy because it will, again, alter the nutritional intake of the person, and nerves need nutrients just as much as the rest of the body does. So, this was a short presentation, but again, it's very important to understand all of the components of a patient's health. So there are many causes of polyneuropathies besides diabetes, which is the most common. Thyroid condition is another very common cause of neuropathy, polyneuropathy, kidney dysfunction, or inherited. All of these are probably the most common ones to cause polyneuropathies in the lower extremities and upper extremities, but it's those aren't the only ones. In order to help you determine that, you need to consider all the medications the person is taking and all of their medical history. So not just, nothing is, nothing is too insignificant, but just be thorough, because that's more, the more you know, the better you can be. So, you don't have to, spend 20 minutes asking the person, during your interview before the test, but make sure that the person is thorough. Even if they fill out an intake sheet, look at it. Don't just, say, oh, okay, I'll look at it later, but look at it before the test, and just be aware of some of the major red flags that I mentioned that can either cause a neuropathy or cause altering of the electrodiagnostic study. So we need to understand the person's entire medical history, and how medications can be affected, or can affect the EEG results. And lastly, not only medications and medical conditions, but also nutrition. Nutrition plays an important role because, as I said, nerves need nutrients as well. So it's important to remember that vitamins and nutritional deficiencies can cause abnormal electrodiagnostic results just as easily as, some of the more common ones that I mentioned regarding diabetes and thyroid conditions, kidney dysfunctions, and etc. So here are just some of the references that I mentioned in addition to the list. If you're really interested in reading it, these may be some articles. Those of you that are in the residency program, these may be some articles you may want to write about as your critical appraisal topic. So there are some nice articles there that you can review. These are all recent articles. I think they're all recent. They're all recent, within 10 years. That's not a criteria anyway, but the more recent the article, the better. So these are just some articles that you can look at, and definitely submit those to your mentor, because again, if you're in the residency, not only do you need to complete the 295 studies, but you also need to complete the one-page summary of articles. So here are some articles. If you need access to full text articles, I'm involved in academic settings, so I can get access to some of these, if not all of them. So if you're interested and want to get copies of articles, just let me know, and I can get you some of these. So this was a short one. So I apologize if you were thrilling and wanting more. But if anybody has any questions or wants to discuss any of the topics, I'll unmute everybody again. And if anybody has any questions or want to talk about it, we can talk about it now.
Yeah, John, this is Mark. I had a question. first of all, it's really good. Is there two questions? Are we going to be able to find this later? As far as is this going to be posted somewhere that we can look at later?
Yeah, all the HODS webinars are recorded, and they're eventually uploaded. I know they're uploaded on YouTube, and I
Okay.
think they're uploaded on the HODS portal. So all the HODS webinars, if you're a YouTube member and you subscribe to the HODS channel on
Yeah.
YouTube, all the webinars are there. Also,
Okay.
I'm not sure if you can access that if you're not a subscriber to the channel, but they're also, like, I'm pretty sure they're also available on the HODS portal that has
Okay.
all the webinars there as well.
Okay. Second question is I'm a little bit new in this, but when there's axonal issues, it generally makes me think of something that is definitively worse. I certainly wouldn't have thought of, or like the prognosis for it generally is not as good as other things when there's an axonal issue. But it sounds like, if you knew it was like a vitamin issue or something like that, then I assume the prognosis wouldn't be nearly as bad.
Right.
That would definitely
That
be
is true.
important to know because I've always thought that way. So it's kind of a paradigm shift for me in that thinking it. Would that be correct or no?
Yeah, with these instances, even though axonal injuries are generally worse prognosis, with things like this where you know the specific cause, it's actually it's a better axonal prognosis. It's still going to take some time to recover, but with these type of things, because it's either stop taking the medication or take a different dose or take a different medication or supplement the nutrition with whatever's missing, then the axon will grow at a fairly normal rate. Whereas if the axon has been severed or been twisted or tied or compressed, you need to stop that compression and relieve the compression before the regeneration can occur. So in these cases, where the cause of the axonal problem is more definitively known, it can be easier to address it once you, like, even with like alcoholism. Alcoholism is another thing that can cause axonal damage, and the way to fix alcoholic neuropathies is to stop drinking. Sounds simple enough, but once they stop drinking, their nutrition, their alcohol is a poison, even though it gives you good things, but it is a poison over long extended doses. And if you stop taking it, eventually the toxins will stop going to the cells, and the nutrients will come back. So out of
Very
all the
interesting.
axonal problems, out of all the axonal problems, these type of problems have a better prognosis.
Excellent. Thank you.
No problem.
Now, John, one that I had a question about too is that it seems that some people that take high doses of vitamin C also have a little problems with blood thinning as well, an anticoagulant effect. Have you seen that at all?
Mm-hmm. Not that much. I haven't encountered that in the literature. I know people. I'm probably guilty of myself. You start having the sniffles, you start drinking orange juice like by the gallon.
Yeah.
But I haven't encountered that too much in literature. It's quite possible, but I just haven't encountered that clinically, and I haven't seen too much of that where it can cause as marked of effect as the even like baby aspirin or the NSAIDs.
Right.
So it is possible, but I just don't know, like and I don't know how much it would need to be, in order to get to that level where it has more of that anticoagulant effect.
Right. Okay.
Anybody else have any questions, comments, concerns? This was a different topic, but it's something I noticed that something to sometimes over neglected, but it's important to consider the whole patient too. So not just drugs and pain and musculoskeletal stuff, but also look at other factors that can affect the nerves and function as well.
No, I think it was a good presentation, John. I'll say good to hear.
All right, good. So it kind of sounds good. So if anybody wants
Yes.
more, any question?
I was just going to say thank you, John.
Okay, you're welcome. Thank you. You're welcome. So if anybody wants any articles, if wants any more information, if the link isn't working, or want me to send you the link that I had to that cheat sheet of drugs, feel free to send me an email, and I'll be glad to share whatever information I have. If not, then I hope everybody has a good night, and hopefully, I know I'm in Florida right now. I'm doing EMGs down in Florida right now, but I heard back up in the East Coast, the Northeast is pretty cold. So I hope you guys are staying warm up your.
Midwest too. Yeah, we're pretty cold up here.
Midwest is worse. Yeah. So stay warm, and I'll talk to you everybody soon.
Sounds good.
Thanks, John.
You're welcome. Have a good night.
Thanks, John.
You're welcome.